Greetings, everyone. Welcome to the 191st session of the online Optom Learning Series, OOLS. And for today's session, we have with us Dr. Cecelia Koetting. Dr. Cecelia practices at an MD/OD practice at Hindsight in Denver, Colorado. Her primary focus is in anterior segment, ocular surface disease, neurooptometry, and also in perioperative care. Dr. Cecelia is a fellow of the American Academy of Optometry and also a diplomate of the American Board of Optometry. She has been an active member of the AOA and has served at both local as well as state officers with the AOA. Dr. Cecelia also lectures locally, nationally, as well as internationally at various conferences and has numerous publications to her credit as well. And today she's going to take us through 5 things which we should not be missing in neurooptometry. And she's going to share some cases and give us her views about what should we be doing if we see such kind of patients. So welcome, ma'am, onto our platform. Thank you so much for spending the Sunday morning with us. And let me just leave the screen time to you.
Hi, thank you. Good morning, everybody. I'm glad you're here. Well, good morning for me, good evening for you guys, but I'm glad to have you here. This is actually really cool. It's a different platform, reaching a whole lot of people in a lot more areas, which I really appreciate the opportunity to do this. Speaking internationally, I don't know that I would say international as this seems to be, because it was, Canada, Mexico, but still technically, so I'll take it. But yes, so this morning, this evening, what we're going to be talking about are some of the more common or uncommon things that might present itself, and more likely things that we might see that are definitely really concerning when it comes to neurology or neurological problems in our patients, and the things that we might actually encounter and what to do with that. So I do have to give my disclosures. These are some of the companies that I consult and do speak for. I am not here as a representative of any of them today, though. So neurology is an optometrist. And I know obviously we're talking to a lot of us in different countries. And so the way that optometry works in every country, and even in the United States, and every state is a little bit different based on what we're allowed to do because of our scope of practice. So it still is good for us to understand what the steps are post whatever we might be able to do in clinic, because it allows us to better maybe tell a patient what to expect or what is going to be done. So obviously amend any of these things for how it works best for you in your country or your state, if those of you in the United States. But a lot of this, again, we're just doing a routine exam to pick up some of these different problems. Might actually manifest in diplopia or in a partial eyelid closure, as we'll talk about with some of these. But we are, a lot of times when it comes to vision, some of these patients' first place to go. So we can still know when to do blood work, or again, when they might need an MRI or a spinal tap. So we'll kind of go through those. Now, how to order an MRI? Again, a little bit different, even state to state and city to city in the United States. But overall, it's good to know when it's something that needs to have it done, like an MRI, immediately, versus this could wait a week. So when you're ordering it, I know for me, I have to decide when I'm going to, if it's emergent, if they need to have it within 24 to 48 hours, I'm probably going to send them to the ER. I like to know specifically which ER I want, because some hospitals will have a neurologist or an ophthalmologist on call, which is good, because then they can draw them into the room for in-house consultation, and it speeds up the process quite a bit. You can also send them with a script to the ER saying, hey, this is what I want done, or what needs to be done and why. It kind of speeds up the process again for those admitting the patient to understand why they're being sent there. Again, why are we ordering it? Is this patient having a sudden decrease in the vision in that right eye with pain? possible optic neuritis, giving them an idea of what to do. I always put my personal cell phone number just to make sure that if they have questions, they can get a hold of me. If it's non-emergent in the United States, we have sites where they can go to have MRIs. They're imaging centers, and so we can call ahead and set up an appointment. But again, you're saying why you're ordering it. You need to have your ICD-10 code in there so that they know with coding and billing how to submit it to insurance. What are we ordering? We're going to talk a little bit about MRA versus MRV. MRA looks at the arteries. MRV looks at the veins. Well, guess what? How does the dye get to the veins? Through the arteries. So if I have to order one, which typically you get one shot with insurance. So if I'm ordering one specifically to look at the arteries and the veins in the brain, I'm going to order an MRV. And specifically, we order those in situations where we're concerned for aneurysms, dissections, or possible cerebral venous sinus thrombosis. So more often you're not ordering those. Those are a secondary. Most of the time you'll actually order an MRI of the head or the orbits. And then if you have nothing there and you think that it is vascular, you order an MRV. With the MRI of the head versus the orbits, well, guess again, if I get an option of one, which one do I want? Well, the orbits are in the head, so I do get some of the scan of the orbits when I get a head. So if I can only order one, I'm going to order an MRI of the head. Sometimes you need to order both, especially in a patient where you think it might be optic neuritis, because about 50% of the time, and we'll talk about this, those patients who have an optic neuritis may also have MS. And so we have to look at the rest of the head and actually the spine, the upper spine, to make sure that they don't have any other lesions, which would actually indicate that they do have MS as part of their diagnosis. But again, a lot of times you don't always get the option of getting both. So maybe ordering just the head, at least to get the overall. But remember that when you get an MRI of the head, sometimes things can get missed in the orbit. And that's because the sections or the size of the slices that they're taking are larger because they've got a much bigger surface area. So they're taking larger slices. So sometimes some very small lesions can get missed that way. So sometimes you do want to end up going back around, especially if you're convinced that of what that patient has, to go ahead and order a secondary scan of the orbits. Pregnancy is okay, but not with contrast. So you want to obviously make sure that they don't use contrast, or let them know at the center that yes, they are pregnant. Do not order in patients with any kind of metal implants, pins, pacemakers, or cardiac defibrillators. Claustrophobic patients do consider an open MRI or Valium, which helps. So when is a CT helpful? Well, only more specifically when we're looking for bony abnormalities, calcification, we're talking about a possible metallic foreign body, or there's fresh blood. So we might use this if a patient has had orbital trauma and we're looking for any broken bones or orbital fractures. We're having proptosis and swelling the eyelids. Or if we have some kind of intraocular, interorbital foreign body. Also, you can use a CT for diagnosis of optic nerve head drusen, but B scan is also sufficient and way less expensive. So this is my ordering form for testing. So this is just the most common things that I've had to send patients out for a scan. It just makes it much quicker for me so that I can put all of my information in one spot and send it with the patient. So, okay, so let's talk about our top 5. Patient number 1, we have a 78-year-old male who has a sudden onset of diplopia, along with a left eyelid droop starting 4 days ago. Oh, and I didn't mention, but if you have questions, don't hesitate to put them in the chat box. I will try to answer some as we go along, especially if they're more about what I'm immediately talking about. And then, of course, we'll still do questions at the end, but don't hesitate to put questions in. Okay, so we've got double vision and we've got an eyelid droop. Okay, cool. When we lift the lid, the diplopia goes away when either eye is covered. Okay, and the patient is seeing images diagonal. So not side by side, not up and down, but diagonal. Okay. And the patient does have uncontrolled type 2 diabetes for the last 15 years. Last A1C 3 months ago was 12%. Not really good. So things were already kind of running through our brain of what's going on. We've got one eye that's down and out. We've got double vision that's diagonal. We've got one eyelid that's kind of closed on the same eye that's having issues. Well, this is essentially what the patient looks like, okay? Full eyelid closure. When we lift that lid, we do see that the eye is down and out. So when we see down and out, that's when we start to think about cranial nerve 3. Because that is the one that controls everything else other than our superior oblique and our lateral rectus. So those are the only two that are still working. It pulls it down and out. So abducens, like I said, abducens and superior oblique are still functioning. Eyelid is shut because the levator palpebrae is also controlled by cranial nerve 3. Now, sometimes you can have it with only a partial lid closure. It doesn't always look as dramatic as that patient. You can also have a partial third nerve palsy, which means the eye may not be completely down and out, but they may still be talking about noticing a more diagonal kind of diplopia. Possible pupil involvement. And this is where it really gets important. So we have to look at the pupil, even when the patient's not completely together, right? We still got to look at that pupil because it gives us more information about what type of concern we have and what level of concern we have. Pupil sparing means that there's no pupil involvement. It's having completely normal reaction. Non-pupil sparing or pupil involvement, we're going to have an afferent pupil defect. So this is one of Opto book. If you haven't ever checked it out, I'm not sponsored, nor do I have any financial anything with them. But I find them really interesting for kind of breaking down a lot of ophthalmological things. They have great, easy depictions like this to kind of just stick in your brain. So check them out. But this is why when we think about pupil involvement, we're thinking what direction. So with the cranial nerve 3, the deep vasculature and the everything that functions, the majority of it, not including the pupil, is actually within the inside of the nerve. And then the superficial parasympathetic nerves, which control the pupil, are on the outside of the nerve. So if we have the two most common things that can cause this, which is poorly controlled blood pressure or chronic microvascular changes, right, from blood pressure or from diabetes, it affects the inside because of the deep vasculature. Okay, so microvascular changes causing problems inside. Now, can it eventually also have pupil involvement? Yeah, but it's also much less likely. More likely when you have pupil involvement, you've got something outside compressing. So that's why we get concerned for an aneurysm when we have pupil involvement. So again, most concerning, a tumor or an aneurysm, something pressing on the outside, versus the most common causes being ischemic changes from diabetes and hypertension, usually not affecting the pupil. Now, we say sometimes, and the reason is because with the pupil involvement, if it's a patient showing up now and it just started, you could not have pupil involvement for up to 72 hours. So you do need to take that into account. So say you have a patient who comes in, like this patient, right? He's got pupil involvement, but he's not been diagnosed with diabetes or high blood pressure. Okay. We're going to be concerned because we're going to say, okay, well, the two most common causes you haven't been diagnosed with. Now, could they still have it? Yeah. And that's going to be part of what we want to figure out. But there's a higher concern for maybe an aneurysm or some kind of compressive lesion. So what do we do next for this patient? Well, in office, in order to diagnose, we're going to go ahead and do versions, ductions, and prisms. We're going to look at the pupils, EOMs, forced ductions, and we'll talk about each one of those in a second. Outside the office, no pupil involvement. I'm going to want to go ahead and get blood sugar, blood work for diabetes. I actually would go ahead and check the blood pressure in office, and then monitor for future involvement, depending on how long it's been there. Say it's been 2 months and the patient just is coming in. I'm not as worried for people to all of a sudden randomly be involved in this, because we know that pupil involvement really peak time is 72 hours after it starts. If they have pupil involvement, they're immediately going for an MRI in the head in orbit with an MRV with and without contrast, and they're probably going to go to the emergency room. Again, because concern with the aneurysm or a compressive lesion. So when we talk about versions inductions, the way that I learned it was a little bit different than I originally learned it in school. And I learned from oculoplastic specialists that I worked with in my previous clinic. And this is a much easier way for it to be consistent between practitioners. So essentially, we're looking at the Purkinje image and the reflection on the eye itself and where it is, and then marking it based on like anatomy, right? So when we use like little muscle light, you have them look straight ahead, and we gauge where it's reflecting. So if it's reflecting right in the center, it's 0. And then as you can see on the depiction, based on how far it goes out, it's kind of, you decide what the amount of where the reflection is based on the anatomy. So just kind of a like depiction of what you're doing. You have them look in each gaze. You see when in the center picture, we see where it's reflected is essentially right at the pupil, which is where we expect for looking straight ahead. Now, when they're looking up, we see that the Purkinje image is actually reflected on the sclera, which is what we expect, right? So these are the average measurements for patients. We have 60 in our inferior and peripheral gaze, 45 central, and then 20 up. And that's because we've got our eyebrows, so we don't look as far up. But that's what we expect. And so this is how we document. So if you looked at my charts, this is what you would see. And then it also allows me to kind of monitor from visit to visit as to how are they doing? Is it worse? Is it better? Where are we at? Forced duction. So remember, forced duction is what we're checking to see can the eye move in the direction that it's not moving? Or is there something physically restricting it from moving in that direction? So it tells us more about orbit versus is it neurological? Because if there was something in the orbit that was keeping the eye from moving, when you do a forced duction, the eye itself won't move in the direction at all. So you can use these lovely tweezers here. I don't do that because that's pretty not fun for the patient. I've also left a couple subcon teams that way back in the day when I first started doing it. I use a Q-tip. I just numb up the patient and then I push the eye, and it works just as well. And so go ahead and push it in the direction. If it moves, we know it's related to nerve. If it doesn't move in the direction it's not been moving, then we know there's something actually probably more likely within the orbit. Prism measurement of deviation. Again, we want to measure this. This is more specific, but this also helps us to check and watch how the patient is doing. So back to our patient. Well, he went to the ER and he was diagnosed with an aneurysm that was approximately 1.8 by 2.2 centimeters. And they actually had there was a previous study, so they actually compared it, but thankfully it was stable. So now what do we do for this? So say this patient had not previously been diagnosed with an aneurysm and we didn't know that this was here. Well, then we need to have them go see an interventional radiologist in the United States. That's who actually is the person would see this patient. If it is a compressive lesion, so say that was a tumor, they're going to go see a neurosurgeon. And so both of those people are going to look at it and decide whether or not is this affecting the patient? Is this something that we need to take out? Is this something we need to leave? And there are times where aneurysms actually get left. Now, this patient here, who is a 26-year-old female who was having blurred vision for a week and 3 months of headaches, she had a very sizable internal carotid aneurysm. And this one actually needed urgent stenting because of the level of symptoms. And again, like I said, if it's asymptomatic, sometimes they leave it. Sometimes they don't do anything with it. Okay. So next patient, number 2. 30-year-old white female comes in with unilateral sudden decrease in vision in her right eye, noted yesterday morning, so new, and no improvement today. States she feels some pain when she moves her eye. Okay, young female, blurred vision with pain on movement. We know where we're starting to think, right? Vision is 2100 in the right, pinhole no improvement, left eye's 20/20. We do have full range of motion, but she is having pain on movement in all gazes. Left eye is fine. Red cap test, that's our next thing. We see we've got 20% saturation in the right eye and 100% in the left. So we're having some issues with color vision here. Color vision plates as well. We're seeing 5 out of 17 versus left eye is 17 out of 17, completely normal. So next up, we look at the back of the eye. Well, went ahead and had an OCT done. So looking at the OCT, we see that even in the grayscale, we can see that the optic nerve is swollen, right? We can see that there's obscuration of the borders. We are losing some of the blood vessels as well there. And then looking down through to the actual thickness, we see absolutely there is, in fact, quite a bit of swelling. Left eye, thankfully, doing normal. Okay. Well, now we want to see, is this affecting the vision and how much is affecting the vision? So visual field. And this is this patient's visual field. So we have an inferior hemianopsia. We've lost most of the inferior vision. We would know based on visual acuity that this patient also has non-central sparing. So central vision is involved in this. Left eye, yeah, we've got maybe a little cluster of defects in the inferior, but I think that, we kind of chalked that up to look at the gaze tracker all over the place, right? So not super reliable. So not of anything of any kind of concern there. Now what? Well, we have identified that the patient has a swollen nerve, pain on eye movement, decreased vision, decreased colored vision, and we are thinking probably optic neuritis given age, right? So we're going to have to send out for my favorite thing, an MRI. And this was this patient's MRI. So we do, in fact, see that in that right eye, we have hyperfluorescence of the optic nerve. So we do have inflammation of the optic nerve. So this patient did, in fact, have optic neuritis. Now, optic neuritis, remember, is inflammation of that optic nerve that damages the optic nerve tissue. 6.4 out of 100% in the United States have this issue or will have this, most often females in their 30s, and that's because it is highly related to being one of the first signs of MS. Triad unilateral vision loss, dyschromatopsia, which is that red cap test, loss of some of the color vision, and eye pain that's worse on movement. Now, remember, when we talk about all of these things, when we talk about what the patient's going to have, that's like the textbook, right? That's not always how it's going to be. I've had patients who've had optic neuritis with vision of 20/25, but they say it's blurred to them, right? I've had patients with 2400. I've had hand motion. I've had 20/20. It will present all over the board. Eye pain is usually pretty consistent. So that one I do typically see in all of my optic neuritis patients, along with the color vision. It also depends on how quickly you're catching them and how inflamed it is. So orbital MRI is going to show inflammation of the optic nerve like we saw in the photo for this patient. Visual field loss can occur. Obviously, it depends on how much, how inflamed it is, where you're catching it again. Same thing as what we're talking about with the loss of vision. Red cap and color vision changes, optic disc swelling. You may or may not have an APD. Patient with 20/20 and not as much visual field damage, probably not going to have a positive APD, but that patient like this one, 2100, severe vision constriction, severe swelling, absolutely had an APD. How do we treat it? Well, IV steroids followed by oral steroids. After the treatment's initiated, we're going to follow the patient. Usually I see them within a week to have a visual field of 30-2, recheck the color vision, recheck the optic nerve on OCT to monitor for improvement. If that patient is not getting any better, after their first round of infusions, I may send that patient back for a second round of infusions. And that's because it's actually 3 to 5 days, sometimes longer. It also depends on if that optic neuritis is caused by MS. It is an idiopathic, or are we talking about something called neuromyelitis optica? Either way, this patient is also going to get referred to a neurologist because we need to assess them for MS. Okay, cool. Let's talk about optic nerve treatment trial because we can't talk about optic neuritis without mentioning it. And this is where the treatment comes from, right? This is why we do IV Solumedrol or IV steroids followed by oral steroids. This looked at 448 patients with optic neuritis seen within 8 days of symptom onset. And that's important to remember is because it is a self-limiting. Now, if this patient comes in and it's been 3 to 4 weeks, they may not benefit from doing the IV steroids because a lot of it may have already started to resolve. Improved visual prognosis with IV steroids versus oral versus placebo. This is what it was looking at. And so the primary outcome said that those who were treated with the IV steroids followed by oral steroids led to a faster visual recovery. But the patients who were treated were 20/50 or worse at the presentation, and those were the ones that had the best recovery. Increased risk in reoccurrence with use of oral steroids alone, and a decreased rate of MS development within 2 years for those who use the IV steroids. So IV and oral had a decreased risk of progression to MS. So the kind of takeaway from this is that will the patient recover regardless of what we do? Yes. However, they will have a higher risk of MS development, and they have a higher risk of long-term more damage to that optic nerve, secondary glaucoma. So that's another thing that we need to think of. That study didn't look at that, but others have. And we do know that because the stress is on the optic nerve longer without treatment, that can cause damage later or start that cascade of damage, creating glaucoma in those patients. So standing orders, this is what I have for my standing orders for these patients for optic neuritis for methylprednisolone IV infusion. And it lets them know how to check for their serum potassium and everything that needs to be done. And they're going for typically a 3 to 5 days in a row. Multiple sclerosis, again, when optic neuritis, this is a big concern for us. 75% occurrence of optic neuritis is the initial symptom in 14 to 25%. So there is a big reason that we need to monitor those. MS risk after optic neuritis, approximately 50% risk of developing MS. 15-year risk is 50%, 25% risk of MS when MRI is normal, meaning nothing other than optic neuritis was seen. Again, remember, we were talking about MRIs of the head because we're looking for other lesions, and that's why. 75% risk that they develop MS or have MS if the MRI shows one or more lesions, meaning it shows the optic neuritis, but it also shows another lesion. Neuromyelitis optica, this is a whole other thing. We used to think that patients who had MO, it actually was a variant of MS, and that led to mistreatment of these patients in such that we were giving them medication for MS, and we realized that actually that was making it worse. So they like to make sure that this is not what's going on in patients before they start MS treatment, because they don't want to make it worse. And actually that has led to better prognosis and life prognosis for these patients, is now that we have a better understanding and we're treating it properly. So the death rate 5-10 years ago was 5-10 years for these patients, and now it's not. So they're doing much better with this. It is still, however, unfortunately, very devastating to the vision when they have optic neuritis related to NMO, because it causes more damage, and the likelihood that their vision is going to rebound is much lower. So they do tend to have pretty significant vision loss with optic neuritis. These are also the patients who may have bilateral optic neuritis. So if you have a patient who's having bilateral optic neuritis, there's a much higher likelihood that they actually have NMO and not MS, or a true MS related optic neuritis. So the way that it's tested for is they look for aquaporin for antibodies, and they're doing testing with their spinal fluid. So that's what they're looking for, as well as with MRIs. But it typically tends to affect the spinal cord, or the spinal column itself, and your visual system more than peripheral system that we can get with MS. Again, already talked about kind of through these that they're more likely to have bilateral and more permanent vision loss, as well as more likely that they're going to show optic atrophy, optic nerve head atrophy after having optic neuritis. Cool. Next one, we're coming into case number 3. So the third thing that makes us wiggle at night. 65-year-old white male comes in, noted sudden decrease in vision in his left eye this morning when he woke up, so pretty sudden. Patient denies any pain and noted a slight throbbing at his temple. Okay. Vision is 20/20 in the right, counting fingers at 5 feet in the left. We have a 3+ APD in that left eye, pretty consistent. And optic nerve head in the right looks completely normal. Left, we've got 3+ edema and hyperemia. Cool. So what are we thinking? Well, no pain on movement, definitely has severe vision obscuration. We also have hyperemic edema versus pale waxy nerve. So given age and gender, little concern for maybe we've got something like GCA or an NAION or an AION, right? So we got to start going through. We're going to get an MRI of head and orbit with and without contrast within the next 24 hours. Normal, no findings. That's good. Blood work, we do CRP and ESR. Because we're looking for elevation, and they were. So now what? Well, we're concerned for, again, because of increased markers of inflammation in the body, pain on palpation around the temple, and sudden loss of vision. We're concerned for temporal artery issue. So, I'm sorry, giant cell artery. And so we're going to do a temporal artery biopsy. So anterior ischemic optic neuropathy, this is one of those other ones we don't want to miss. Now, more often than not, this is actually not what the diagnosis is, but we want to make sure that if it is, we're catching it, right? Because it's not just an eye issue. This is a vascular issue. This is blood vessels everywhere in the body. So we want to make sure that we're getting the diagnosis. Has multiple names, right? We've got AION, we've got giant cell arteritis, temporal arteritis, but either way, it's a vasculitis within the medium and small sized arteries. Typically, patients are over 60 years of age, no actual reports of GCA in a patient under the age of 50. And that's important to remember, because if this is the same thing presenting in a patient that's 35 or 45, this is not what they have. You're looking at the wrong tree. Things that they might notice, signs and symptoms, the big ones that we think about, and this patient actually had, is scalp tenderness, jaw claudication. When we ask them about fatigue when eating, they may also have polymyalgia of the arms and shoulders. They may have fevers, night sweat, and weight loss. So remember, this is not just an eye issue. So we're going to go through a couple of myths here. Myth is that giant cell arteritis is a disease of the elderly. Well, that's a myth. Again, 50 and over, yes. But remember, anybody under 50, it's less likely that they actually have that. There has been no reported cases. If you have the first, congratulations, make sure you write that up, but that's probably not what's going on. Second myth, giant cell arteritis is primarily an ophthalmic condition. Like I mentioned, it is a systemic issue. Cranial arteritis, yes, we will have that. That's kind of where we're going with the eyes. Non-specific inflammatory disease, large vessels. There are large vessels elsewhere. So manifestations within the complaints of what the patients are going to notice. Headache is the most common at 86%. Ocular involvement is actually only 20 to 30%. It's not very much. So we'll talk a little bit about the percentages in relation to the biopsy in just a second, but only about 40 to 50% are going to have that scalp tenderness. Again, that 20 to 30% ocular involvement. They're the things that we think about as far as our ding, 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 like this is what's going on, or these are the questions we ask. we don't actually get that often. Jaw claudication, 40 to 50%. So when we look at those who symptom specificity with GCA, so we're talking about those who actually have that complaint, and then what it looks like when we look at their biopsies. So I've only had one biopsy out of 10 years that actually came back positive. That doesn't mean that I only had one patient that had GCA. The percentage of likelihood that they're going to have a positive biopsy is pretty low. And I've had one person ask me at one time, what about if we did a bilateral? Would that be better? Well, no. Then they don't do a bilateral, and it's because that if it comes up negative on one side, it's still going to come up negative on the other. I asked my oculoplastic surgeon, and he said, no, nobody does that. Could you? Sure. But again, I mean, you're putting your patient through something, and we know that the likelihood of a negative biopsy is pretty high. And there's a couple reasons for that. I know that they talk about doing a larger segment at about 3 to 4 millimeters, and that's because there can be skip lesions. So the likelihood that you'll get a false negative is lower if you do a larger section of that temporal artery. But again, so let's look at this. In patients who had giant cell arteritis, these are people who were actually diagnosed and treated, 82% had a headache. And of those 82%, 55% had a positive biopsy and 45% had a negative biopsy. 95 to 99% who were diagnosed as having GCA had ocular involvement, but only 50% had a positive biopsy. That means 50% of the time, even though they actually did have GCA and ocular involvement, they actually had a negative biopsy. Jaw claudication, 98% who had GCA also had a jaw claudication. 48% had a positive biopsy, 8% had negative. And then as you see, we kind of keep going down through there. So the biopsies really just aren't that slam dunk that I feel like we've been told. So the actual diagnostic criteria, you only have to have 3 of the 5 of this. So when we send these to the primary care doctor or whomever we're going to have manage this, because typically that's not something I manage. I help in the diagnosis, but this is then something I'll get them started on medication, but typically then I send it to their primary care doctor or to a rheumatologist, because this is something that is a long haul on the treatment. I mean, it's about a year that they're going to be on steroids or some kind of treatment. Typically, so these are the criteria based on the American College of Rheumatology in 1990. They have not changed since then. They have to have, again, like I said, 3 of 5, over the age of 50. So as we were talking about age, new onset localized headache, temporal artery tenderness or decreased pulse, SED rate of over 50, biopsy for necrotizing arteritis with so a positive biopsy or that temporal artery biopsy. So again, like I said, even if they have a negative biopsy, we know that is maybe not the slam dunk. It still can be considered GCA based on this. So blood work, remember when we're doing blood work, we're looking at the ESR-CRP. ESR is an elevated response to acute and chronic inflammation, and the C-reactive protein is an acute phase protein that increases quickly with inflammation and decreases faster than that ESR. And that's why we get both, right? We do CRP for, is it an issue now? ESR will give us more of a long story. And so we want to look at both of those for markers. And that tells us a little bit more about what's going on, or maybe they're out of an acute phase but they did have something. You do want to make sure you don't start oral steroids until after the blood work. You can start oral steroids prior to the biopsy, but no more than about a week prior to that. I believe actually 72 hours prior to, you want to hold off. So this is my lovely lab requisition form. I use this to order blood work, and I send it along just so it makes it easier for me to just kind of tick on which ones. Mentioning again, the biopsy, skip lesions can occur, which decrease the accuracy and specificity. We do not want to start oral steroids till after the blood work, but up to 72 hours prior to the biopsy is okay. So as we've been talking about systemic condition, and this is what, if you had a positive biopsy, this is what it would look like. Those are the giant cells. Now, what if it's not that? Well, then we're talking about a non-arteritic ischemic optic neuropathy. Now, so the blood work comes back normal. The age is 40. The biopsy is normal. ESR, CRP, like I said, normal. These patients, it's a diagnosis of exclusion, but it's a localized ischemic event at the junction of the optic nerve. As mentioned, typically younger in age than an AION. Sudden painless vision loss. They are going to have a severe defect. They're going to have a less severe defect as far as the vision than an AION, but the vision will still be affected. They possibly have an APD. Most often they do. They'll have pale disc swelling and some flame-shaped hemes. And the pale disc swelling is different than the patient that we have, which had a hyperemic disc swelling. Again, like I said, diagnosis of exclusion, you got to rule everything out. If you do an MRV, a lot of times they'll have microvascular changes or signs of a chronic microvascular change. That means blood vessels have been struggling, right? We get that a lot with age anyway, but in these patients, we do tend to see a little bit more. Otherwise, 40% will show some improvement in vision over the next 6 months. Monitor that with visual fields and checking vision in office. The optic nerve edema usually goes away within about 6 to 8 weeks, but you do want to keep watching, right? Long term, we need to watch these patients for risk of one, contralateral eye involvement if it's related to things like sildenafil use or erectile dysfunction medications. They're still at a higher risk. And then the other thing is we want to watch for long-term glaucoma. There can be, some treatment needed. So we see here pale waxy nerve. This one is cupped out. This patient had an NAION, but it was longer ago. They aren't going to start to have this cupping out till they're at least about 3 to 6 months out, because we go from having swelling, right, to now it starts to thin out. And so that's what's going on with this patient. And obviously visual field's going to be affected because we've got quite a bit of damage. So this patient who actually popped up, this is a part of another lecture, but looking at it from the opposite direction. So this patient saw me after seeing my glaucoma specialist and came to me, and looking at that, I go, that's not just glaucoma, right? This is so asymmetric that we know something else has gone on. So going ahead and getting more testing on this patient. So no history of diabetes. I did order blood work on him just to get an A1C to make sure. High blood pressure, says it's controlled with oral medication. Blood pressure was good in the office that day, but we know we don't really have a chronic way to watch it. But also, if you look at the blood vessels, it doesn't have a crazy amount of tortuosity or anything else that makes me concerned for hypertensive retinopathy. Patient does currently use sildenafil and has used for the last several years. No history of major surgery. So when we're talking about NAION or damage to the optic nerve, you want to ask about alcohol use. You want to ask about bariatric surgeries or any kind of surgeries involving the gastrointestinal system, because they can have issues with absorption of different vitamins, especially the B vitamins, which then leads to nutritional deficiencies, and you can get optic neuritis and issues from that. So we ask about those things, also asking if he's had any surgeries where there was complications and a severe loss of blood or blood pressure drop. And typically those tend to be more bilateral when we see this. But my winner on him was, okay, it's probably sildenafil. And we know that that can cause NAION. Question was, though, that I really wanted to see, is it sildenafil and do they need to stop, or what is it? Because I was kind of curious what is the mechanism, right? Well, so what I started to find was that, so this study looked at a 2006 study looking at 13,000 men, showed no increased risk in NAION in patients on sildenafil when compared to similar population not on the medication. It was an incidence of 2.8 per 100,000 men over the age of 50. Okay, let's look at another study. So 2015 study, a little bit more recent, had 1,100 cases of NAION that also showed no increased correlation with the use of either sildenafil or a PDE5 inhibitor, so another erectile dysfunction drug, within 30 days of onset. What they found, though, was that cases were more likely to have hyperlipidemia, diabetes, hypertension, myocardial infarction, and cerebrovascular event. So what does that mean, right? That means that the patients who had an NAION while on sildenafil were at a higher risk anyway to have an NAION because they had cardiovascular problems, okay? So vascular issues can cause an NAION. We're talking about that, right? So they were already at a higher risk that it was going to happen. Sildenafil didn't necessarily pose an increased risk in itself because of the medication, but just because they were needing it. So that's something to kind of keep in mind. And then I let the patient with their primary care doctor, or whomever prescribed it, know that this is what's going on, that there is a risk that they'll have it in the other eye. And it still may be beneficial not to use it, but that's kind of up to them. NAION treatment, right? So in school, I was taught that there really wasn't a treatment. Starting to work with my specialist, my oculoplastics, he taught me, nope, there can be, you can. And he said, there's this one study about this one person, this one time. So I went and looked at it, and it said that in a study that was done in the 1970s, said that patients may benefit from use of 40 to 60 milligrams of oral prednisone over a 1-month taper in their long-term visual recovery. So showed 85% of patients treated with 60 milligrams of oral pred showed a visual improvement compared to those untreated. So that is one thing that I do, but I did want some other studies, right? So there was another one in 2008 looking at 696 eyes, that were treated within 2 weeks of onset. They were given 70 milligrams of oral prednisone that was tapered over 1 month. They found that 69.8% of the eyes who were treated had an improvement in their visual acuity, and only 40% of those untreated had an improvement. So you got about a 30% increase potential of improvement in visual acuity when given. So if it's not going to hurt anything, then why not? Right? Even if it's only 30% and we do see 40% still getting better, I would personally still take that chance and rather take it. Now, that being said, remember, we're talking about these patients having cardiovascular issues or chronic microvascular issues, and may have diabetes. Well, a diabetic patient, we don't really want to put them on 70 milligrams of steroid because that might actually make their diabetes worse. So, other option, levodopa. You can use levodopa for NAION. This study showed that if it was given within 15 days of onset, so remember very early, like with the steroids, 19 of the 23 on levodopa had improvement in their BCVA. 6 out of the 14 in the control group who did not receive it had improvement. 4 out of the 14 actually got worse. So it did show that it helped these patients. Patient number 4, we're going to go through the last couple here in the last 10 minutes that we have. 45-year-old female presents with a bilateral peripheral vision loss that has been gradually worsening over the last few months. Central vision's good. She's 20/20. Anterior posterior findings were unremarkable, but here's our visual field. That's why we do a visual field, right? We need to look for constriction. So, and we have it, bitemporal loss. So concern for that in a young female is tumor. Yep. And it's not a tumor till it is. With a pituitary adenoma, these are pituitaries that cause that very specific bitemporal or something that's compressing right above the optic chiasm. And when it compresses that, we can start to get visual field defects. You can actually get motility defects. A lot of times when pituitary is involved, we'll get multiple cranial nerve palsies, meaning that multiple nerves will be unfunctioning at the same time. They'll get diplopia, nystagmus, can get optic nerve atrophy long-term. And this can be caused by different, depending on the different size, is going to be how much it's going to affect. So the way it's classified is by size. Macroadenoma is over 10 millimeters. Microadenoma is less than 10 millimeters. And then they look at, is it functioning or non-functioning? Functioning meaning it's secreting hormones and it's causing other problems, or is it non-secreting? So depending on how big it is, what it's affecting, is it secreting or non-secreting, kind of leads to what they do for treatment. Now, testing for these patients, we want to make sure that we're doing visual field and we're reporting that to the neurologist, actually specifically a neurosurgeon, because that's going to help them determine whether or not they want to do any surgery. And then the other thing is we can get a junctional field defect, which is less common. Again, just depends on how large it is. MRI of the head with and without. Treatment is going to go, again, endocrinologist, because we have to find out, is it secreting or non-secreting, and then a neurosurgeon. And they may do a resection. They may do medical treatment to try to shrink it, or they may just monitor. A lot of these are monitored. Now, something to know with the patients who've had these and they're stable and they're monitoring, in our female patients, when they become pregnant, one, the adenoma can actually get worse because it causes, during pregnancy, hormones causes the pituitary gland to swell. So it may actually make the adenoma become larger and cause some increase in visual effects of it. And also, those who do not have an adenoma, it can have what we call a pseudoadenoma. So the pituitary gland swells, again, during pregnancy anyway in some patients because of hormones, and that could all of a sudden cause these patients to have some symptoms that would be associated with a pituitary adenoma, although it's not actually an adenoma, it's just a swollen pituitary gland. Patient number 5. So we're walking into our last one here. 30-year-old male presents with ptosis of the right eye and notes that his pupils are abnormally different in size. Okay. So we got a slight ptosis and we've got pupil changes. What are we concerned for here? Horner syndrome. Yep. So typically it affects one side of the patient. We get that triad of ptosis, meiosis, and anhidrosis. And if it's been ongoing and it's longstanding, these patients will actually have heterochromia. So they'll actually have different colored eyes. The eye that's affected typically will be lighter colored. I don't think this one is. No, it's not. Sorry. So what could be the causes of this? Well, this is a long nerve. So unfortunately, there's lots of areas where it could be affecting, right? So it could be carotid artery dissection, aortic dissection, trauma, demyelinating disease, like our MS, anything that would affect any of the nerves, tuberculosis, sarcoidosis, cluster headaches, Pancoast syndrome, which is Pancoast tumor, herpes zoster, because viruses affect a lot of the nerves and we can get a lot of issues from them. I would argue to throw also herpes simplex in here and potentially COVID, because that's another virus that has had a lot of neurological effects, and then giant cell and malignancy. So again, why do we have all that long list of things that can affect, and why is the lung in there? Well, because this is the journey of that nerve. It is a lung journey, and it does go down around by our lobe, the upper lobe of our lungs. So Pancoast tumors, which is specifically an upper lobe tumor, can start to compress on it and cause this. So we do a directed evaluation. We start to get emergent neuroimaging if the patient is having any neck or facial pain, because we're concerned about a carotid artery dissection. If they have any history of recent neck trauma, ipsilateral vision loss, headache, transient numbness or weakness of the opposite side of the body. So those are things that we're kind of more concerned are going to be on the first portion of that nerve. And if we are concerned for acute carotid artery dissection if it's significant risk. The reason we're concerned is because they're at a significant risk for a stroke within 2 weeks of onset. Other things that we do and we can do in office, if we are not thinking it's in that first category, we can start to look for the supersensitivity of the nerve, because it's been essentially deprived of certain compounds in our body. So we want to see, is it super sensitive? The way that you do this is cocaine. We occasionally had cocaine in our office, medical grade. I promise we're not picking it up from elsewhere. But it was used for testing for this, but it would be left over from certain surgeries that my oculoplastic surgeon would do. So we could use diluted cocaine. that was very rare. Otherwise, aproclonidine, and again, that's not something a lot of us have in our office, but because I did quite a bit of neuro, we kept some in the office for the patients when this would occur. But the reason we use that is it's a direct alpha adrenergic agonist. And so we're going to use that to figure out if that alpha-1 receptor is sensitive. So you use 1 to 2 drops. You don't need a lot. No dilation if there's no lesion. If there is a lesion, you'll get dilation. So because they're super sensitive and the receptors are reacting to that aproclonidine, causing dilation. So what do you go past that? Well, you can continue to localize the lesion. You can use hydroxyamphetamine or phenylephrine. Again, we don't typically have hydroxyamphetamine. We often have phenylephrine because we're using that for dilation. You can actually do a dilution of, so ours is typically a 2.5 phenyl. So we just dilute it, and you have to wait at least 24 hours after having done the cocaine iopidine, and then put that in. And again, you're looking for dilation and no dilation. If there is no dilation, the patient has a preganglionic lesion, which means it's in that first area. Postganglionic means it's after the ganglion. So it could be anywhere in the pancoast area up through the neck. So more likely something carotid versus brain. So other than that, guess what? Most people aren't going to do this direction. They're just going to send them out for testing because it actually is a little bit quicker. And often we don't actually have any of those drops in our office. But if you so choose, you can absolutely try to locate your lesion. And those are our top 5. What questions do you all have?
Well, thank you so much, ma'am, for taking us through. It was very wonderful to look at all the cases. And I think you did what you did mention in the introduction as well. Like these are common, but not so common, which we will see. And it's very important to not miss them and, properly diagnose them rather than just misdiagnosing them as well.
Absolutely.
Ask you one question, which is very directly related, because you did talk about the disease as well as the, I would say, the pharmacological treatment as well. But, our scope of practice in this part of the world, in most of the countries, we don't have an access, or we don't have pharmacological treatments which we could prescribe. So what do you think would be the best thing we should be doing in terms of testing and diagnosis? Mm-hmm. Anything which you think that this is something which you should do because this is in your scope, and rather, of course, refer for pharmacological treatment. So anything which the key tips, what you think we must not miss out and we must definitely do? Yeah.
I think that no matter what, it's gathering as much information as you can. Even if you can't treat, you can at least start to have an idea. Visual fields, and somebody just asked this. So visual fields is really important because it tells us about what's going on behind the eye, right? We know it can tell us what's going on inside the eye, but if we're lacking any visual findings, like we're not seeing anything, that visual field is going to give us more information about possibly localizing or what the problem is. Now, the person asked a 30-2 versus a 24- with pituitary adenoma. I, in general, do a 30-2 if I think there's any neurological, and that's because I want to get as much as the periphery as I can. Would it be wrong to do a 24? Absolutely not. It is fine to do either because you're still going to get information. But I typically tend to just go ahead and do a 30-2 to get more information.
That's right. Okay. Yeah. So that was the question which popped up, which visual field tests. So you did mention that visual field is important. Any other tests which you think that, of course, doing pupils and all that you have been talking about, but anything specific to neurodiagnostic tests which you think that probably we must do on all patients, like color vision as well, you did mention. But any in-office quick tests, something like that, which you think is really important?
I mean, yes, the pupils doing the quick color, even if you're not doing a color vision, doing a red cap test. So just putting up your your dilation drop with a red cap and saying, okay, cover each eye and tell me, is it different between the two? That can start to give you an idea of, is there something neurological or is it something more anterior within the eye itself? Yes. I mean, obviously we want to order an MRI if we can. And if that's within our scope, again, that's going to be dependent on what you're seeing and dependent on where you live. So if you feel comfortable and you can, take that next step and order the MRI and blood work if it's needed.
That's right. Yeah. Yeah. I think we usually refer to the radiologist for the MRI for, probably, of course, we do some of them specifically when it comes to electrodiagnostic. I think most of the optometrists can perform, but when it comes to these kind of higher order MRI, CTs and all that, we do refer out.
And if you have like an ERG or a PERG or anything like, right. Yes. Use those. Absolutely. I don't typically talk about that a lot, and that's because most people in the United States don't have that. So it's not something I always add in. I try to go with, what do we have? What do we all commonly have in our office? But if you have those, by all means, absolutely do that, because that can still get us more information.
Right. Yeah. This is a question probably asking more about in terms of lumbar puncture. Besides lumbar puncture, is there any associated tests which you would perform? So for BIH and HIH kind of issues, any other ways to measure the ICP apart from the lumbar puncture? Yeah.
That's a really good question. So what you're going to find is technically no. Are there indicators? Yes. So on your MRI, if a person has increased intracranial pressure, you're going to often have a flattened pituitary, empty sella, and flattening of the posterior globe. So there'll be other indicators that'll pop up on an MRI to say that they have that, because they're, the part of the reason we do an MRI before we do the lumbar puncture anyway is to rule out that they don't have a Chiari malformation and that they won't herniate or have herniation if they have a lumbar puncture. So we have to make sure, can they even have it? So there are those patients where we just have to go based on the MRI findings because they have a Chiari malformation and we can't do a lumbar puncture. But is there any way to actually numerically measure ICP? Unfortunately, lumbar puncture is the only way.
Yeah, that's right. Great. And I think one more question which directly came out to me in terms of color vision. Is there any specific color vision tests which you would prefer in terms of these patients, or you would just go with the standard Ishihara test?
Standard Ishihara. Yep.
Yeah, that should suffice.
That should suffice. Yeah. Because a lot of these times you're not looking, like if you're going to pick up gross abnormalities. If you have like the 100 Fahrenheit 100, you can, that's going to take a lot more clinic time and you're not really going to get that much more information out of it unless you're looking for, Dutan, Trotan, whatever the difference, right? We've got all these different ones, but that doesn't necessarily aid you in your diagnosing. So I try to keep it as simple as possible when I talk about neurology, because frankly, that's the way that most of us practice. Obviously, there's more specific practices where they're really getting into that. But I think for all of us, Ishihara and red cap, that's about all you need. I think you'd be good.
Yeah, we just want to know whether there is a defect or not a defect. You don't want to categorize it at this point. Probably,
no.
Yeah. In the future, if you want to look at it, categorization, then it's a different story. You can spend more time, and as you say, the more advanced the test becomes, the more clinic chair time you will give to the patients. You would probably want to give that time for doing more neurological based tests than to do a routine test, right? Yeah. Absolutely. Yeah, great. I think with that, we have taken all the questions. Oh, there's one just popped up. This is asking in terms about BIH, in terms of is it curable, and have you encountered any of such patients in your practice?
So BIH or IIH, is it curable? No, because in essence, this is a genetic issue. and so there's a couple things that go along with it. So our understanding used to be that it has to do with weight, right? No, it doesn't necessarily. It actually has more to do with hormones. Other things that we're looking at are the dural transverse sinus in the brain. And they're finding that there's a correlation between narrowing of that and patients who have IIH. So is it curable? No. Have I had patients who get off of their medication and do fine? Yes. So a couple things is getting the hormones under control, because a lot of times with these patients, again, females, hormones out of whack can cause us to put weight on. So that is why, yes, there is a correlation, and sometimes getting a little bit of weight. The study showed 10% decrease in weight in those patients who are a little bit overweight or obese. That can create a fix of it, essentially, right? It can get it back under control. Same thing with patients who have polycystic ovarian syndrome. They have a higher likelihood, but that's because a lot of their hormones are out of whack. Sometimes that can lead to weight gain. So getting that under control can get them off of the diuretics. Also, I find that patients who are postmenopausal, the likelihood that they're going to have a reactivation or have problems is a lot less likely. So we're able to get them off of taking the medication as well.
Yeah, that's right. So that's great. And I think while we were, listening this lecture as well, we now understand that, the scope of optometry is not just looking at the eyes. We need to get the blood work knowledge. We need to get the blood pressures, the diabetes level. That's why we learn all of this during our optometry school as well. And CTs, MRIs, and connecting all the dots together is something which is really important. And you may not see them every day, but the day when you see these kind of patients is you must know these things exist, and you must be able to help these patients as well.
Yeah.
Yeah, great. So with that, thank you so much, ma'am, for spending this Sunday morning with us and sharing with us the cases. I think the cases, what you shared with us, I would just reinitiate. These are very common. We might see them once, probably in a month's time, and that's the time where we will remember, okay, these are the things we need to look at. So thank you so much for going in a case series direction, which is really important. Yeah.
And just know that we can help.
We can definitely.
We're actually very important in these patients. Yes, absolutely.
Right. Great. So we do have session planned over the next few weeks. We will share the details. Until then, take care, be safe, and I hope to see you in the next session. Take care, everyone. Bye-bye.
Bye. Thank you.
Thank you. Have a good Sunday. Bye.